Good morning, Group C. This is Cavin and Mowgli. He's looking very pretty today. Here today to talk to you about RSV, or Respiratory Syncytial Virus. It's a highly contagious respiratory virus. It has a greater impact on infants from 2 to 6 months, especially those who are premature or born with any kind of congenital defect or predisposition. Bronchiolitis, that inflammation of the bronchioles, is the number one cause of hospitalization in the United States in that age bracket. So, and that is a cause of an RSV, a viral infection. And bronchiolitis is that inflammation of the bronchioles leading to tissue, that bronchial tissue kind of necrotizing. Don't tell that to the parents. Sloughing off, going down in the lower airways and causing a pneumonia-like kind of reaction to it. Most cases aren't going to get that far unless they are in that immunocompromised territory or the infection gets on so much. Most cases are going to be mild. They're not even going to need to go to the hospital. If they're a healthy 2 to 6 month old, stay. Biggest thing is this, along with flu and cold, December to March, in that winter kind of cold months, is going to be our biggest trigger point. Epidemics are when they're going to show up. Daycare, premature births, all that stuff, crowded environments, passive smoking by the parents, any of that can lead to a more severe RSV, bronchiolitis kind of downturn for these kiddos. Good history is super important for RSV. Fine. The signs and symptoms are usually going to peak around like 48 to 72 hours for an RSV infection after it incubates, after it sits there. And infants go from, like we've been talking about, they'll go from a simple cold-like symptoms, runny nose, stuff like that, to respiratory failure very quickly. So they'll crash hard, just like we've been talking about with Justin. Hallmarks for RSV: you're going to get severe apnea in those younger kiddos. They're not going to be able to take that breath. Cough, respiratory distress, wheezing. Sometimes you'll be able to hear it without your stethoscope even. Tachypnea, difficulty feeding. So dehydration is huge for these kiddos. Cyanosis, if it goes from that mild to more moderate, more severe. And then you'll see, obviously, the kind of subcostal retractions, nasal flaring, and the grunting. These kids are just having trouble breathing. So that's just an overview of RSV. We will have our scenario with Layla here. Well, sit. Can you sit? No. So Layla is post-breakfast snoozing, but we'll try and make it look good. So we're working the EDs in the night. January is about the time 10-month-old infant comes in, and she is showing from our initial chart before we get to see the patient. We know she's febrile, got a little bit of a fever. Mom says no past medical history. I'll talk to her mom. Her name's Layla. Creative, I know. And after speaking with her, we find out that Layla here has been in daycare, and kids have been, she says, dropping like flies through the daycare. So that's tick number one. And she herself is just surrounded by a pile of tissues. Mom's covered in she's got tissues everywhere. There's just a lot of snot coming out of Layla here. So Layla herself, we'll put her on a 0.5 liter nasal cannula. She's going to have a SAT, we'll take that, of 93% on that nasal cannula. She's kind of lethargic, which fits. for her age, 10-month old, she's not fussing around, she's not moving, she's kind of down. And without even using the stethoscope, I can hear wheezing coming from her. So I know she's working pretty hard. After kind of that initial, I'll do an assessment. I'll have mom come and kind of sit here with me, just so 10-month-old Layla doesn't get scared. I've got treats for my Layla. So we'll go ahead and check respiratory rate, and you can even do this while you're talking to mom, is check that respiratory rate instead of having to like crowd over this 10-month-old who's kind of sick. Respiratory rate's 54, a little bit tachypnic. Heart rate, grab that, 192. It's a kiddo. So high is okay. This is still a bit tachypnic for a kid. Take a blood pressure, 85/50. Also pretty normal for a 10-month-old. Again, a little elevated. So all three of those are a little elevated. That matches up with what our patient here is dealing with. You see some subcostal retractions because we're good RTs. We'll go ahead and lift up her shirt. We'll see that kind of subcostal retraction going on. Nasal flaring, even on that nasal cannula. Take her temperature. Got a little sensor. However we do it. 101. Now I'll ask you guys, is that normal? Is that within our range for kiddos? That's enough time to answer. It's a little bit high. So we're not looking at like 104, 105. This kid's not baking off, but 101 for a kid so young is still a little bit spooky. They're working hard. Expiratory grunting. So on exhalation, you're gonna hear that grunt. Head bobbing. So every time they take a breath, they're gonna be moving their head. Expiratory wheezing, heard, and then put on your stethoscope. I won't put it on because I can't hear. You're gonna hear crackles on exhalation. So you're gonna hear that. That's gonna be a bilateral crackles, and then also more wheezing on auscultation. And you do find out from mom, might ask you guys, is it important to know what their gestational age was? So how long was Layla pregnant with Layla? And we found out from mom, because we're awesome RTs and we do a good history, that she was 39 weeks, which is completely healthy, normal birth time. So this kind of is a mark to tick off for these RSV kids, is Layla was not premature. I'm thinking already with the daycare, with all that stuff, my mind's already going towards RSV time of year. We're sitting here in January, cold months. And with all these symptoms, if you want to go look in our disease book, page like 554, I think, there is bronchiolitis RSV, just like we do the scoring for COPD or asthma or stuff like that. There's bronchiolitis scoring as well. And so with all these symptoms, with how she's presenting, this is a non-emergent, mild case of bronchiolitis. At least that's where I'm leading. We're not allowed to diagnose it. We'll get to that. So treatment, acquire her baseline vitals. History, the doctor orders a nasal lavage. What is lavage, you ask? Lavage is going to be, first, since she's so snotty and there's just tissues everywhere, we're going to want to, she's going to not like you for this, but knowing what we know, wanting to guide the best care, we need to get a good sample of her schnoz sample. So we're going to clean out those secretions. We're going to use a Q-tip or whatever we can to get the kind of super drippy, the stuff we don't, is not going to give us anything. We're going to get that out of there first, and then we're going to do a saline kind of flush through that nose, and we're going to take that bulb almost, and we're going to get that sample of a little bit of saline and that kind of deep mucosal snot. That's where this RSV, that deep, dark, moist, that's where that RSV viral incubation period loves to happen the most. So doc orders nasal lavage. He also orders a chest x-ray for her to kind of look at what's going on. Oxygen continuation for her, so keep her on that nasal cannula. Suction as needed by an NPA, so that nasal pharyngeal airway. They'll hate you. And right now, with how she's presenting, I was able to clear some of it just with her snotting and mom using tissues and Q-tips. I wouldn't suction this kid. Oh, you're just gonna piss her off. But if for whatever reason, like, the apnea gets worse, she's having more trouble breathing, we'll need to suction and just stay on top of that so that we don't lead to a more moderate severe case. Doctor orders IV fluids for a kid, and I'll ask you, do 10-month-old kids like getting IVs or OG tubes? Do they like getting feeding tubes? No. Even these lethargic ones, that'll tick them off. So if the doctor orders IV fluids, I think more in line with like hydration protocol, make sure that these kids have proper hydration. That mucus, that's not all of it. You don't want that thickening up. You don't want it getting tenacious. You don't want it to get that. She's already having trouble feeding at home. So if you can get oral fluids, if you can get some Pedialyte, no sugars, no Gatorade for kids, but if you can get just some oral fluids, convince mom to kind of help you out with that if you can. But if that can't work, we're going to have to drop an IV, get fluids in Layla. Look at her. She's so lethargic. So that's doctor ordered. And due to the presence of wheezing and the possibility of, just because it's bronchiolitis, itis, inflammation, the airways may be reactive in these patients. This is kind of a tough one, ordering albuterol or any of our kind of beta-2 bronchodilators. In these mild cases, all the studies and stuff say it's not indicated. Doctor has ordered albuterol 2.5 milligrams in 3 milliliters for Layla's weight, and we're going to do that through a small volume neb, mask, and mom. Those are our tools. So we got to be prepared for anything. If she gets more severe, get that IV ready. If we need to do suctioning, and in super severe cases, these kids are going to have to go on mechanical ventilation and be intubated, and we don't want that for our younger pop. Chest X-ray. What do you guys think that would look like for bronchiolitis? I'll tell you, obviously. Chest X-ray on her might appear normal. More moderate, severe cases of RSV, you're going to have hyperinflation. She's trying to breathe really big. She's not able to get air in, so you're going to have that hyperinflation. You'll have a depressed diaphragm due to that same kind of hyperinflation. You'll have bronchial opacities because bronchiolitis. Those bronchioles are inflamed. They're angry. That lymph tissue surrounding all those bronchioles, you're going to be able to see that consolidation in there. And again, listening to it in the more severe cases, you're going to have just that decreased sound in those inflamed airways. It's dense, it's thick, hyper-resonant. You get hyper resonance. You'll be able to hear that more. You might do for the more severe cases some steroids, some prednisolone. Mary's in my group, so talk to the pharmacist how to say that. But that would be a 17 milligrams in 5.5 milliliters. That's an inhaled corticosteroid. Get that inflammation down in more severe cases for her, just because the side effects of corticosteroids and the long-term effects on kids. I wouldn't look at it. Post-treatment, Layla's getting better. So we are able to wean her after we do our albuterol small volume neb on her. After we clear it out, we wean it off. We do find out from our nasal lavage, takes about an hour for the lab to run that. RSV is present. We know what it is. So good job nailing that down. She's approved for discharge with a prescription for an MDI spacer and mask of albuterol at home in case she does get any worse. Like I said, this is a 48, 72 hour peak, and then just supportive care is the biggest thing for these kiddos, either in the hospital or at home. So for discharge, physician's going to give that albuterol MDI at 90 micrograms per puff, holding chamber mask attachments, and 4 to 6 hours as needed and you don't need to use it if you don't need to. And teaching mom is going to be the biggest part, and that's the breathing exercise I just want to do with you guys, since it's, I have a dog and a 10-month-old. It's tough to walk through a breathing exercise. So MDI education. Layla has no idea how to use an MDI, so we'll walk through. We'll have all of our components. We're going to teach her. All right, so I'm going to teach you how to use an MDI. We'll go through that. I'll have you kind of paired it back to me, and then make sure everything's good to go. So start, we're going to shake our MDI, get it all shaken up, especially if we haven't used it in 24 hours. We're going to remove that cap. We're going to check for anything in there. We're going to assemble first we're going to prime it. Before we put our spacer and our mask on, prime it twice out into the nether, put on our spacer, put on our mask, and then we're going to press. We're going to actuate it, and this is before we even attach it to Layla. We're going to activate it. We're going to get that medication in that spacer, and then we're going to apply the mask with a good seal on Layla. She's probably not going to like it right now. It's fine. She's lethargic. And then no more than 15 seconds. You're holding her. You're cutting her hair off. So no more than 15 seconds, mom. Remove that. Wait 45 seconds. You're going to wait for her to kind of breathe it in, get it going, and then repeat as necessary as prescribed by the doctor. Additional education for at-home care with these kiddos is, what can we do to help her normal oxygenation, her normal breathe in, breathe out? What do we learn in therapeutics can help? Humidification. Good answer. Nice. Cool mist humidifiers at home for these kids, wherever they're sleeping, wherever they're hanging. Can't be bad. Cool mist too. You don't want to do a hot mist, especially with these kids. They can get burnt if that hot mist is, and we in the hospital can monitor that and make sure it doesn't. But at home, don't risk it. Do the cool mist humidifier. Hydration. She's having trouble feeding, but mom needs to do whatever she can to make sure she's healing. She's growing already as a kid, already having trouble. Make sure she gets enough fluids. That's Pedialyte. That's not Gatorade. That's not sodas. That is water. That is milk. If you can get her to feed normally, either through, and I get, after being discharged, she's probably going to want to feed after going through all this stuff, after getting some help, after getting that care. And yeah, I think that kind of covers a lot of it. We'll look at anything. Immediately she needs to contact the doc, because these kids are known to good, and then they'll get worse once they go home. So if the kid has any worsening retractions when Layla is breathing, so these subcostals, you start seeing that suprasternal retraction, you start seeing it up here in the neck. Call back into the doc. Doesn't eat, doesn't drink, can't do that. We might need to bring them back in, do that OG tube, get that IV in them, maybe have them stay a little longer if they can't eat and drink at home. Layla's diapers are dry, but doesn't urinate in 6 hours. That's not normal for a kid. I don't have kids, but I have a dog, and if he doesn't go for an extended period, it's like, he's doing okay, man. Same thing with these kiddos. And then crying, producing no tears. So they were just wailing and red in the face and purple, but no tears coming out. That's another good sign of dehydration in these kiddos. They can't tell you they're thirsty, they can't tell you they're hungry, but you can look for those signs. Prevention for RSV, especially in the immunocompromised kiddo population, the prematures, the PDAs, the congenital heart stuff. Avoid kissing your baby. If you're sick, if you have a cold, you love them, I know. Hold off. Someone else is sick, don't let them handle your baby. I don't care if it's your aunt. I don't care if it's grandma. If they're sick, don't handle my baby. Don't want them getting RSV. You can explain it to them. Clean or disinfect where you know your child's going to be playing. So if they have a nice play area, a nice playpen, daycares, again, that's just a cesspool. But with COVID, they've kind of increased precautions. They've increased cleaning habits, and that's decreased a lot of RSV over this past year. It's down significantly, but we can do a different presentation on that. Wash your hands before and after touching babies. Babies are gross. Don't pass it to the next one, but also don't give it to them by not washing your hands before. And then, just be aware if your child is going to daycare, what their sick kid or sick child protocol is. Some of these bigger ones, they're not going to send them home. They're going to get them Tylenol, slap them on the butt, and they go back to play. But if your kid is more at risk, you need to be aware of that and maybe change daycares. So that is Layla and RSV. I hope you guys learned a little bit something. Went a little bit long. I apologize for that. We'll see you this afternoon. Thanks.